Welcome to today's edition of Mental Health Matters. Today we're going to be talking about managed care. I have Chris Flannery on the show today, who is an outreach specialist, and he's going to tell you all about it, the services that this particular program provides. He's going to talk about what you have to do to be qualified for this program, so get you a drink and some snacks, and stay tuned. Hello, Chris.
Hello.
Thank you so much for taking the time out your busy schedule to kind of tell us about this new program.
Of course, it's good to be with you.
Yeah. So why don't we start by you telling us a little bit about yourself and just how you got into this type of work?
So, well, I guess before this work, I was a firefighter and a paramedic, and so I actually did respond to folks that would benefit from this program. I really wish it was in my back pocket when I was responding to people on the street, because a lot of the time it was just, palliative care, trying to get them to the hospital so that they could have a warm bed and a warm meal. And a lot of the services that are inherent in this program actually help to mitigate some of that situation.
Nice. So you transitioned from being, so apparently I think you had to be an EMT first and then a firefighter, and now you transition to more of like the healthcare side, I'm gonna say.
Right, yeah, like the policy side, the implementation side. Yeah.
So how long have you been doing this type of work?
So just over a year. So I work for Harbridge Consulting,
okay, nice.
And we're a consulting firm that works with the Department of Healthcare Services, the California state entity that actually dispenses the care, or actually works with the county partners to dispense care. Nice. Our contract is to help implement this program, this Health Homes program. It's a Medi-Cal program, and we do that by educational outreach, by reaching out to in the communities. Nice. For all the counties that are going to be going live.
Nice.
And trying to get the information out so that folks understand what it is and can take advantage of it if they need it.
Nice. So did you guys start this, or did you get involved with the program from the ground up, or was it already running?
So this is from the Affordable Care Act.
Okay.
And so when the program was being designed, this was keeping in mind that there's a certain section of the ACA, it's section 2703. This gave states the option to create these health homes, in quote, programs for folks with certain chronic conditions.
I'm smiling because you know your stuff. I could just the pronunciation, just the different acronyms and stuff.
Yeah.
So okay.
Well, we'll see. You asked me a question I don't know. Hopefully we'll be able to answer all of them. So.
Well, that's what we got all the information in front of us for, and so that is you'll be fine. So let's talk a little bit about Health Home program. So let's kind of dive into that and explain to what that is.
Okay. So. Well, the whole Health Homes program is a new Medi-Cal benefit that's going to be actually went live yesterday. So as of July 1st in Sacramento County and other counties that are going live in Group 3. Nice. So what it is it's basically a care coordination effort. So it provides all of these services. There's actually 6 core services. Nice. And these services will help folks with, if they have things that are going on with their medical situation, or any issues that are, that they work with every day, that they're having trouble mitigating or working with themselves. It gives them a care coordinator.
Okay.
And that's basically the MVP of this program. They're the main point of contact for both the patient or member, as well as the rest of the care team. And I'll explain in a second that second bit. But this care coordinator, what they do is like their name implies, they coordinate the care for the member, and they make sure that they get to their appointments. They make sure that they're complying with their treatments. They make sure that the communication with all of the care team members, and I'll explain that second bit again. The care team is comprised of all of the different members that work with that patient or that member over the arc of their health care. And what that means is, folks that they're specialists. So if they have a cardiologist, an oncologist, whoever, they would be part of the care team. Pharmacists, nutritionists, these folks are also part of the care team. And this also includes housing navigation.
Nice.
So one of the tenets of this program is to provide a housing navigator for folks who are chronically homeless, as defined by the HUD and by AB 361. And that defines what chronic homelessness is. But if they are indicated as chronically homeless, then they can qualify for this program under the acuity criteria. There's all this criteria for this program. But they would then get this housing navigator. That housing navigator would then be able to work with the system and actually navigate the system for them to try to get them under a roof and maintain that tenancy. So we're not looking for a 2-week stay. We're looking more for like a 2-year stay or more.
Oh, nice.
I understand, and I've heard by many of the community partners that we work with that like Section 8 housing, for example, is 8 to 10 years long, the list. And so that's a consideration that the housing navigator will actually have to work with for each individual. So this, it's a tough situation, but that's their job. That's their sole job in this particular program, is to just ensure that we're doing everything we can to get them under a roof and safely.
So do some of these people who qualify for these particular programs, do they have to, well, I guess I should rephrase my question. Is there a certain age, or do you have to be on NorCal, or does that qualify them or disqualify them?
Right. So we can talk about the qualifications, but there is no, to answer your question, there's no age qualification.
Okay,
so you can have everybody from 0 years to 99 and more. The main qualifications are, there's 3. One, they have to be a member of the managed care plan that services Medi-Cal in their area, in their county. In Sacramento, there's several. And then second, they need to satisfy certain chronic condition criteria. These chronic conditions are actually representative of the top 3 to 5% of utilizers of Medi-Cal. So these are folks that they have very complex issues. There's multiple things that are going on for them, and by virtue of that, there's multiple things that they need to do to mitigate their problems. And so as a result, that can be overwhelming for a lot of people. And so this care coordinator is supposed to help with that. The third qualification for this program is the acuity or complexity criteria. That could be 3 or more of the chronic conditions that we mentioned previously. Or it could be they had an inpatient stay in the hospital. They were admitted to the hospital in the last year. They had 3 or more emergency department visits in the last year, or they're chronically homeless. And if that's the case, then they satisfy that criteria. If you have number one, that managed care plan membership, then you have the chronic condition criteria satisfied, and then you have the acuity criteria satisfied, then you qualify, and then it becomes a benefit for you under Medi-Cal.
So what are some of the I forgot what you said. I'm trying to think of some of the oh my God, I'm having a blank. They had to be, what are some of the sickness per se, that's what I'm gonna name it, that they had to have in order to qualify? Just kind of throw some of it out there.
Right, so the chronic conditions that you're looking for. They're actually like 4 little boxes
Okay.
that we want to check. So if we check one of them, then it satisfies it.
Okay.
The first one, if you have 2 or more of the following: COPD,
Okay.
dementia,
Okay.
diabetes, coronary artery disease, chronic liver disease, chronic kidney disease. And substance use disorder actually is one of them as well.
Okay.
If you satisfy, or if you have 2 of those chronic conditions, then you satisfy that box, and then we're good with the chronic conditions, and we can go on to the acuity criteria or complexity criteria.
Yeah.
Another one would be hypertension plus CAD or coronary artery disease, other cardiac problems. So basically looking at the heart. If you satisfy those, then we can check off that box and move on. Another is asthma as a single criterion. So asthma is a really dangerous disease process or pathophysiology. When I was responding, that was one of the main respiratory issues that I encountered. You just a little protein that gets in their system, they ingest it, they breathe it in, or whatever happens, they don't tolerate it. Their bronchioles seize up, and suddenly they're horizontal, and then people are calling 911 for these folks. So asthma became a single criterion. I would presume that because it's so dangerous. And then we're looking at that SMI population. SMI stands for severely mentally ill or impaired, and we're looking at people with major depressive disorder, bipolar disorder, and then certain psychotic disorders such as schizophrenia. And that population is included in this program as well. There's a caveat there. So the implementation of this program is staggered by 6 months. There's 2 cohorts per county that's going live. So the first cohort is going to be all those those physical chronic conditions plus substance use disorder. Basically everything but that one box that checks off the SMI population. They go first, starting July 1st, just yesterday in fact, and in Sacramento County and in others, quite a few: Imperial, Kern, Los Angeles, and all up and down the state. And then that second cohort, 6 months after. So in this case for Sacramento, that'll be January 1st of 2020. That's when the SMI population will be accepted for benefits for this program.
Wow, you know what? This program seems like it has a lot to offer.
It really does.
I was involved with a program, but it wasn't as intensive as they didn't have all these elements that they offer and stuff, but because they was limited by age, because the contract, you had to be a certain age and things like that. But they had like social workers, they had nurses, and then the clients had them be enrolled in IHSS and things like that. So they was kind of navigating services through that way, but it definitely was not able to kind of stand up to what you guys are doing here, because there's no age limit, so it takes the cap off the services that people can get help from, as far as being, a certain age bracket. And I like the fact that they have they put addiction in there, especially substance abuse, because and it's funny because I was just telling a friend on my way here too. We was kind of talking about people that we know who has a problem with alcohol. And I was telling her that a lot of people don't look at alcoholics or people who have substance abuse or substance abuse addiction. They don't look at a lot of people don't see it as a disease, but clinically it's classified as a disease.
Absolutely.
And a lot of times when people are addicted to drugs or alcohol, they really cannot function in their normal capacity.
Absolutely.
They do things that they normally wouldn't do. Some of them suffer from depression, anxiety. They get lethargic, and so. But when you don't look at it from a clinical perspective, you tend to classify people who fall into these brackets as not saying they're not normal, but sometimes I feel like people put them in a box where they don't have a disease or issue that's going on and stuff.
Right, and that's a misconception that's been going on for a very long time. It's absolutely true that folks with substance use disorder kind of have the bad shake, as it were. Because it's assumed to be a behavioral problem. that people choose to take this drug or to drink or whatever. But truly, it is a medical disease. It's a medical pathophysiology.
Yes, yes.
And it is something that needs to be addressed. Otherwise, it just self-perpetuates, and you have that positive feedback loop, and you keep on going back. Imagine you're going home to the couch after a long day working, and you sit down. We have something called the basal ganglia, and it works with our habit-forming loop. And so you find yourself in this environment that's so common. You sit down on the couch, and suddenly you're thinking, oh, you know what? I really want that glass of beer. I really want that glass of wine. The same thing is, I mean, that's analogous to drug use as well. Folks may come home if they're, let's say they're addicted to stimulants or something like that. They come home and they sit down on that couch. Suddenly they're thinking, oh well, I need to shoot up. I need to I need to take my pill, pill, or whatever it may be. And it's not a that's not faux pas. It actually is a disease. It is a problem that needs to be worked out medically.
And I know someone personally who kind of deals with some of the situations that you just described. And this individual, he is such a loving and caring person, and but at times he feels like he needs this in order to be able to function. And then you get all the other stuff that comes along with depression, suicidal thoughts, and it's just but I understand, because I'm in the field, and I kind of even family members who fall into this category too, so I kind of have a little bit of background. But it's hard to explain to people sometimes who don't have a background. This same friend I was just telling about, her and I kind of go back and forth a lot, because I try to explain to her, especially from like family members and things like that, I try to explain to her, some of the things that goes on, the symptoms and things, and she doesn't understand that because she doesn't come from that background. And her whole thing is, well, you just need to be done. You try to save the world, and you sending your brother this, or you're doing this, or whatever, and it's hard for me to explain it. I found myself getting a little bit perturbed because I'm trying to explain to her, but she doesn't come from this background, so it's kind of like pointless in a sense. But
well, it's interesting that you make that point. One of the services in this program actually addresses that communication with the patient or member. So I think a lot of people are guilty of this, if you want to say that. You go to the doctor, you go to a clinic, whatever that may be, and you have this white coat person in front of you, and they're telling you what to do. They're saying, oh, hey, you need to take this medication, you need to do this treatment, you need to blah, blah, blah. But they don't speak they speak a different language, literally. Medical terminology, that's, I mean, Latin and Greek, right? So the people don't understand what's being explained to them. And so what this program tries to do, it mandates that you have to communicate what the actual disease process is going on with this patient, and make sure that they understand using layman terms. And let's say that still the member doesn't understand. Well, the care coordinator or other members of the care team can actually accompany them to critical appointments in order to have things explained to them, or even if they just need a shoulder to cry on, as it were, they have that resource. It's something that's inherent within the program.
Do you think that, just because you have the EMT and firefighter background, do you think that there is a close correlation with kind of what we're talking about now and what you guys was doing back then?
I mean, like absolutely. When you respond to folks that are on the street, that are homeless, that maybe have substance use disorder, or maybe even if they just are under hard financial times, that wears down on people. You develop depression and anxiety and other mental health problems as a result of your situation. Now, when we would respond to people on the street, we would see that time and time again, and we knew that there was nothing we could do in an emergency sense right there there right now, acute problems happening as a result of this chronic issue that's been going on for ages. And we would get there and know that we really couldn't do very much other than get them to the resources that they need at that moment. And it was frustrating because you knew that really what we were doing was just palliative care. We were just taking care of them, making them feel comfortable en route to the hospital. And then they get to the hospital, and who are they talking to? Maybe a social worker, and sometimes not even that. It really is just a really hard situation, and there's no easy solution. But at the very least, this program is trying to mitigate it. It's trying to make it less of a hurdle to jump over. And really, you get this big old care team, all these folks that are actually helping propel you forward. You being the patient or member who qualifies, and it makes it so that they don't have to put as much effort into their self-imposed effort into their health care. They have somebody else backing them up.
That's exactly right.
Right, and they have somebody that's going to explain things to them, somebody who's going to be able to show them which door to choose, and what's going to happen behind each one of those doors. And so, they say knowledge is power. One of the services in this program actually talks about coaching those members about their diseases and actually educating them about what this medication is going to do for them, what the reason why these symptoms and signs that you're feeling and experiencing are happening. And typically when somebody has data in front of them or information in front of them that they accept and believe, they're going to make an informed decision. And given that this care team is doing everything they can to ensure that they are well educated about their health problem or issue, and they make the right choice typically, and as a result get better. So that's, this program actually is, the goal is to have a net zero liability in that for actual funds. That Medi-Cal patients are expensive, and the top 3 to 5%, that accounts for somewhere around, I believe, 40% of the total Medi-Cal budget, and so that's a huge number. I mean, we're talking about lots of dollar signs, and the goal of this program is to try to bring back that number by reducing readmissions, by ensuring that people are compliant with their treatment modalities and medications. And inevitably, when somebody is compliant and they actually do take their meds, they do what the doctor is asking them to do, they typically get better. They trend upward. And so as a result, they're not going to the hospital as often. They're not having to go to the emergency department to have an emergency taken care of as often, because over the long run, over a chronic time period, they are compliant and getting better.
So I've done several shows in the past, just recently, about homelessness. What do you think, or why do you think people that are homeless are being, well, it's just my opinion, but I think that people that are homeless are somewhat being misunderstood.
Absolutely.
But why do you think that is? I'm just curious, because you get programs like this that can actually help people, to get well and stay well and be in a better situation. But like, if you don't know about these programs, or if people have a misunderstanding about people who's homeless, I feel like people won't kind of use programs like this as a resource. I know I will, for sure. But why do you think, people that's homeless, why do you think that they're misunderstood?
So I think there's certain stereotypes that are assigned to, I mean, every demographic you could imagine, right? So this stereotype that we're dealing with here with people who are chronically homeless, maybe they have some sort of mental disorder, and so people will make this assumption that they are mentally disturbed, or that they are incapable of taking care of themselves, and we see as a result of their incapability, that they're on the street.
Yeah.
But that, you know, it's simply not true. We see, you know, and other people think that people with mental illness may be dangerous. You know, there are certainly certain pathophysiologies within the brain that may cause a little bit of more aggression, or maybe maybe there's a little bit something. But that is the vast majority of people that suffer from mental illness are not dangerous.
Correct.
And so it's one of those stereotypes that have perpetuated over and over and over again, self-perpetuated, just as a result of what they see on TV and movies and other media. And so it's a misconception that it needs to be corrected, and people just need to be educated about it. When they see somebody who's has mental illness, their first assumption is, what am I going to do about my safety? I'm worried that they're going to come over to me and hit me or whatever. Exactly. For the most part, that's just simply not the case. Yeah. So yeah, I think it's just a stereotype that needs to be, there needs to be education about it. And as a result, I think that the zeitgeist of mental illness will include more of the people who are nonviolent, rather than the movie spectacular that you see on TV and you know, the silver screen. You know, I like to tell people, and this is just my little quote or my little saying, that everybody experiences some form of mental illness in their life. I mean, if you have, just say for example, we go home and something happened to a loved one, that's going to alter our mental state. Absolutely. We're going to be depressed, we're going to be upset, angry, or whatever, may experience anxiety or whatever the symptoms may be, but that is a form of alteration to your mental state of mind. Absolutely. And so for me, when I try to tell people that I think who it's hard for them to grasp what mental health is, I try to break it down to the simplest form where they can see themselves in a situation. And I think for me, I think that kind of helped the light bulb to go off, so to speak. Right. And I actually have had people who actually responded and got it because I broke it down in simplest terms that way, because it's true. Yeah. You know. Absolutely. And as far as people being homeless, I know a lady was on here, she was talking about too, about how like some homeless people, it's hard for them to get jobs because they don't have a physical address. A lot of them don't, you know, have the resources to create resumes and clothing and different things like that. Right. And they want to come out that situation, but they just don't have the resources. Or maybe not even access to a shower or something like that, just to get themselves clean so that they can present themselves at an interview. That's difficult. It's very difficult for people. And so that's why it's people like you and I and other people out there that's in the field just doing the work, able to exchange resources and kind of lead these people to places where they can give them the help that they need, so to speak. Absolutely. Yeah. That's the reason why I do what I'm doing. Nice, nice. I can definitely tell you got a heart to help people, which is good, and we need more people like that in the healthcare or human services field, so to speak. I really think it comes down to empathy. You know, put yourself in somebody else's shoes, right? You know, you find yourself in a situation. Let's say, okay, you know, you have. I'm sure there's plenty of people who have all the means they need, and they're having trouble putting themselves in those shoes. But imagine if you didn't have those means. Yes. Right. And suddenly you were thrown out on the street. Yes. You didn't have that fancy car and house and all the bells and whistles. Suddenly you have nothing. Yes. You know, okay, well, what's your next step? I'm sure that you have certain expertise that got you the means that you have at that moment. And so, well, maybe you have to apply that, and so that you can try to bring yourself out of this hole, right? But it's not that simple. No, it's not. Right. And so it makes it so that you have difficulty compounded by other difficulties, compounded by other difficulties, and then you have all the social interaction with you being a homeless person and all these assumptions that are being made about you, and so as a result, it's harder for you to get that job. It's harder for you to you know, apply yourself in the way that you know how, or maybe you don't yet, but you just need a little bit of help to get there. And you know, it's frustrating to see that people just they don't use that empathy. They don't use that type of hey, what would happen if this was my situation? Exactly.
Exactly.
And that's what I apply every time. Like whenever I would respond to somebody, I would assume that this was the worst day of their life.
Exactly.
And I was there to try to make it better.
Yes.
Right. And so I would hope that somebody would do the same for me if I called 911 or if I asked for help. Just a helping hand, reaching out.
Yeah.
I would hope that somebody would reach down and pick me up.
Yes.
And so that's what I applied to my work. I try to be in their shoes.
Yes. It's interesting you said that, but I want to talk about if you do have resources. I remember one year I was renting, and my landlord at the time, she kind of played me in a sense because she was actually selling a house, and I didn't know it. I was still paying rent and stuff.
Okay.
And so she kind of gave me like 30 days to be out.
Oh, yeah.
And it was just like, oh my God, my world was shaking up. And so when you're renting or buying a home or whatever, it's a process.
Yeah.
They got to do reference check, they got to check bank statements, they got to make sure you get a job, just all this other stuff.
Yeah.
And so the worst thing for me at the time, for my situation, for me was, I gotta go and stay in a hotel, because it was literally boiling down to that.
Yeah.
Now I had the money, I had the job, but it was like I couldn't find the right place to fit my needs and stuff,
Mm-hmm.
And as a result of that, I kind of rushed into a situation, and to come to find out the situation I rushed into, I was actually getting scammed. I had got scammed.
Man, I'm sorry.
Yeah. And so
Talk about a gut punch.
Yeah, it was horrible. It was horrible. And then when I did finally find a place, I rented a place. It didn't really meet my needs. So I was staying in an area that I wouldn't normally stay in, and it was just horrible. But it was just, for me at that time, it was just the worst thing that could be going on with my life. So I can imagine people who don't have the financial resources and who don't have a job, and it makes it much more worse. Much
worse.
Yeah.
I mean, when you don't have income, and then suddenly you're thrown out.
Yeah.
What's your recourse? Right?
Yeah.
So then it makes it even more difficult for them to try to figure out what they're going to do.
Yeah.
And what this program actually tries to give them that resource. So at least mitigate the uncertainty, the inability to navigate complex government programs. That Housing Navigator for specifically chronically homeless folks, that's their job, is to try to dispel the fog around what it means to navigate these programs. Like, government programs are inherently difficult to navigate usually.
Yes.
I know that folks in government absolutely try to make it as simple as is possible, consistent with the law. But sometimes there's a lot of back and forth that just it breaks it or changes it so that it makes it just that more difficult, and then we're talking about politics, and that's a different conversation altogether.
Yeah.
But at the very least, this program takes some of the worry away, because you have that huge team of people that are helping you.
Yeah. So how's this particular program funded?
So it's funded through so let me back up. The Affordable Care Act, so ACA, Section 2703, as I mentioned previously, gives states the option to create health home program for folks with certain chronic conditions. This is Medicaid's or Medi-Cal. Those are synonymous in California. So this is Medi-Cal's answer. DHCS created this program using that as a guideline. And so what's going to happen is this program is actually going to have what's called enhanced federal matching funds. And what that means is 8 quarters or 2 years from the implementation date, whenever that may be in this program, 90% of it is actually going to be coming down from the federal level, from the Affordable Care Act. So the ACA actually, all the money is earmarked and ready to go for this program for the beneficiaries. The way that it's structured, that money goes to DHCS. DHCS works with the different managed care plans by a PMPM, or a per member per month, or a capitation rate. And then, the managed care plans then contract with different providers that what we call CBCMEs, which is a happy government acronym for community-based care management entities. So these CMEs, these care management entities, they contract individually with the managed care plans in the area. And these folks may already be providing services that the Health Homes program provides. So this is just an opportunity for them to then subsidize that and be able to bill Medi-Cal for the care coordination services they were doing, or the housing navigation services they were doing, the nutritional guidance that they were giving. Different things that are in this program. If they qualify as a CBCME, and there's quite a few qualifications for it, then they can engage with the managed care plan and negotiate that contractual term, and then provide these services and actually get paid for it this time, instead of just doing it the way they usually do it without that subsidy.
I know the organization that I was connected with, they will always have like a huge wait list, and I felt bad for the participants or clients that was waiting on this list, because sometimes, if someone they knew from the community or loved one or family member recommend somebody, they kind of got pushed at the top. And I understand how things go and politics go with that. Always bothered me, because you had people that was probably on the wait list for 3 or 4 or 5 or 6 months, and then you get somebody just out the blue who level of services is not as difficult as the people who was on the wait list for those 6 months, and then you just put them to the top. So do you guys have a wait list at all, or?
No, we do not.
Wow.
So this program is a benefit. So if you could imagine, we have a box right here on this table, this imaginary box. This is Medi-Cal Basic. So if somebody has Medi-Cal, would have all the services that they're in. What the Health Homes program is an added benefit, another box on top or to the side if you want, that adds these benefits alongside the base Medi-Cal. And it doesn't change or delete any of the services that are already inherent within Medi-Cal. It just adds to them. It becomes an added benefit. So if they qualify, if they reach the qualification, one being that managed care plan enrollee, 2 satisfying the chronic condition criteria, and then 3 satisfying the acuity or complexity criteria, then they qualify, then they're entitled to that as a benefit. And so that's the way it's structured. It is an added benefit. There's no wait list, and there's no cap.
That's really, really good. So you guys can serve as many clients as you want in this program,
so long as they qualify.
Wow. Wow. And because I know that other program, they was only able to serve so many clients, which capped them out and stuff. So wow.
It made it more difficult for people who really needed those services to actually gain them. And this one, the qualifications are stringent, and because we're aiming this program, it's aimed at the population that utilize Medi-Cal the most. These are the top 3 to 5%, and so these are the people who, just as a matter of course, they are the most expensive patients to mitigate within the Medi-Cal system. And by improving their health, by giving them all of these resources, it's intended to bring that cost down by reducing those readmissions, by reducing the number of times that they come into the emergency department, et cetera.
How many counties do this program serve? Do you know?
So off the top of my head, we're looking at 12, I believe. And if I can look at it right here. San Francisco was Group 1. They went live on July 1st of 2018 for the substance use disorder and chronic conditions, and then 6 months after that, January 1st of 2019, they went live with the SMI population. Then the second group, which actually went live with their substance use disorder and chronic conditions on January 1st, like San Francisco did for their SMI population, Riverside and San Bernardino down south in Southern California, they went live at that date. And then now we're in the Group 3. So Group 3 actually has 8 counties. So we have Alameda, Imperial, Kern, Los Angeles, Sacramento, San Diego, Santa Clara, and Tulare counties that just went live yesterday. for the physical conditions and substance use disorder. And then 6 months after that, it'll be the SMI population and Group 4, which is Orange County. They went by themselves. They're going to be doing the same staggered implementation. That's 6 month. Separated by cohort.
Yeah, so they pretty much is implementing these programs just kind of one step at a time, so to speak, by counties.
Right. Yeah. Okay. And this, it really had to do with which counties were going to be ready in time. And,
correct.
There's a lot of back office things that need to be done.
Yeah.
As it were, if you're familiar with that term, in a doctor's office.
Yeah.
You have the front office, which is all about the patients, and then you have the back office, and that's all about the administration of it. You know? And so, like doing the billing, doing the all the logistical support of it.
Yeah.
And so there's a lot that needs to be done on behalf of or by the managed care plans and the CBCMEs to stand this program up, because we have all of these different services that are being given to the members, and there's quite a lot of logistical support that needs to be integrated in order to be able to do so. In order to qualify, there's certain parameters that pertain strictly to the CBC opinion. I really hope so, because I think it's an incredible program, and like I said, I wish I had it in my back pocket when I was responding to folks. But let's hope. Yeah, we'll see.
Yeah, I think once these programs all start rolling out and they see the benefit and how it's really changing people's lives and helping people, I think people can, start to go to the local congressman and start to advocate and just expressing their concerns about not having programs in other counties.
Right.
And I think, politics will eventually have to succumb to what's really helping the people, because it's all about helping the community anyway.
Absolutely. We can only hope. Right?
Yeah. So what do you think that what programs like this? How do you think programs like this will ultimately alter our future as far as healthcare is concerned in a better way? Do you see it pushing pushing our healthcare system in a better direction in the future, or do you just think it just will eventually maybe fade out? Not just this program, but other programs that's very similar to these programs as well.
I think it's wonderful for people.
Yeah.
I think that this, as a result of having this type of service for people, they'll be able to propel themselves over that hurdle. They'll be able to get themselves where they want to be. And everybody has dreams. Some come true, some don't. But when you have something backing you up like this, and something so comprehensive like this, it just affords people the opportunity to get to where they want to be. And I think, and as a result, and this is my opinion again, but I think that when people are happy and they feel healthy, and they don't feel like there's something holding them back, they typically do great things.
Correct. That's exactly right.
And so I think that these types of programs are wonderful for people, because they simply have no other recourse as a result of it being gone. If this were to disappear, there would be folks who, they would look to other programs, of course, they would look to other options, but they wouldn't be as well taken care of.
I agree.
And they wouldn't have the team standing behind them.
I agree.
Of hardened professionals in medicine that want to ensure that they're as well as they can be. That's where it's at. And me being a former practitioner, actually going out and being the tip of the spear, as we like to say, and being the first one on scene or talking to people as a medical authority, this is the kind of thing that I wish that I could just, oh, hey, by the way, there's this Health Homes program and it might help you. Why don't you contact your managed care plan? Why don't you see if you qualify, and hopefully it'll be something that'll help you get out of the rut that you're in, or maybe it'll be something that will it'll just help you live the life you want to live.
Do the Department of Healthcare Services, do they audit you guys and just kind of go, because I know sometimes when you're getting contracted or people are receiving service through contract and things like that,
right.
they, you know, there's a very intense audit that goes on every so often. Maybe it's every 6 months or every year, every 2 years. Are they involved to that level?
Absolutely. You know? So I mean, this is a newer program, so there haven't been audits at all, but we keep meticulous records and trying to, so our sole purpose really is to do educational outreach, to try to get the information out. My job as an outreach specialist, and I cover Northern California, I go out to physically go out to the counties and engage with different community-based organizations, different stakeholders that work with the targeted population that we're looking for that may benefit from this program. And I educate them about what the program is. And we offer this service free of charge. So you know, what we do is, if you're a community-based organization that works with this particular population, you know, I'm looking for you. You know, I'm trying to find. I'm cold calling. I'm emailing. I'm actually walking out there and handing out flyers to each of these organizations and saying, hey, you know, we have this new program. It's coming to a county near you, and you know, this will really help the folks that you serve. So here's the information. If you want, I can come in and I can train your executive staff. I can train your leadership team, and I can train your staff so that they know what it is, and so that when somebody inevitably comes in and asks about it, it's like, oh, hey, I heard about this. What's this HHP? What's this Health Homes program? Do you know anything about it? They're gonna, you know, these are folks that are asking their trusted advisors, really, like people who they work with on a day-to-day basis. These CBOs, these community-based organizations that work with these patients. Those patients will come in and say, hey, I heard about this program. What is it? And you know, wouldn't you want to give an educated answer to it?
Yes, exactly.
And so, yeah, that's my job. I try to reach out as widely as possible and cast a really wide net.
Yeah, you should. Well, you emailed me some information, but if you guys have flyers or even if you have business cards, you should leave them with me, because I'm connected with a lot of different people.
I certainly will.
Here in Sacramento, and I can definitely pass this information along. So we talked about the eligibility. So I want to get more in depth with the enrollment process. Because I want people who watch this to know how and what they would have to do in order to get enrolled.
Okay, so there's three main ways that people enroll. The first one's going to be the most prevalent. So what DHCS compiles a list, and it's called the TEL, or Targeted Engagement List, right? And so what that means is they take all of what are called ICD-10 codes. These codes they pertain to the certain chronic conditions.
I know exactly
so like we were talking about back office stuff, right? Where like in the back office they're like writing reports and stuff like that. Those codes pertain to that disease or that issue.
So is that what makes you eligible? Those codes.
And that goes into your medical record, right? And the DHCS sees that, oh, this patient has these specific ICD-10 codes. Okay, well then perhaps they may qualify for this program. They compile that list and then they send that off to the managed care plans. And the managed care plans then take that information, compare it to their own lists, you know, with these specific ICD-10s, and then they contact the members, and by whichever means that the member had elected to be communicated with. So whether by telephone or text or snail mail or email, the managed care plans engage with the membership and actually ask or tell them, oh, hey, there's this new program, the Health Homes program. These are the different services that it gives you. If you are interested in this kind of thing and something that may help you, contact us and we'll get you started. That's the first and most prevalent way. Oh, by the way, that TEL, the Targeted Engagement List, that's updated every 6 months, so it may be out of date. So that, you know, that's
good to know,
right? And so that, you know, the managed care plans, they're constantly like looking for people that may qualify and try to help them get what they need. But there may be a gap in that information, that data. But anyway, so the managed care plans engage the folks. That's the first way. The second way is, you know, you just go to your primary care physician or provider, and get a physical, or you go in for an appointment, and they recognize in you the symptoms or those ICD-10s, those particular chronic conditions, and say, oh, hey, Chris, I think you need to look at this program. It may help you. Yeah. And so you can get referred by your physician. The third way is probably the least prevalent, is by self-referral. Okay. And now, maybe as a result of this show, people will see that people can sign up for themselves. But given that, this is probably least prevalent only because it's it's quite rare. Yeah. I'm talking about me walking down the street with my hand truck full of materials that I'm trying to drop off, and somebody saying, hey, Chris, what's in the box? Or hey, Guy, what's in that box? And I explain it to them, and they're like, oh, hey, okay, that sounds good. I might be able to use it. And then they self-refer. So yeah, the members that think they may be able to benefit from this program would absolutely be able to call their managed care plan, or even call HCO hotline, or Healthcare Options hotline. It's a 1-800 number, and it actually might be bannered right here, I don't know. But if you call HCO, they'll get you in contact with the people that you need in order to start enrolling. If they don't know the answer, just keep on asking for other agents that may know. But if push comes to shove, just call your managed care plan in your county, and then they'll be able to start you down the road. Nice, yeah.
nice. And thank you for going into details with that, because there are people that is going to watch this particular program, and when you want some type of services, you're going to be thinking like, okay, how do I get involved? Or how do I get enrolled? Yeah. Especially if you know that you qualify. Yeah. So absolutely. that's good. So, in your opinion, what is the most challenging thing about this program, or getting clients enrolled? What would you say would be the most challenging, if it would be a challenging situation?
Well, I guess, it's okay. Well, I guess that some people have had trouble with actually getting the referral through. I'm not, I don't have very much data coming back from the managed care plans and DHCS about that type of thing, but anecdotally, things that I've heard on on the street, as it were, you do see that there's some kind of disconnect sometimes. Right. But I don't see any downsides to this program, because truly it is a Medi-Cal benefit. Yeah. So if you qualify, you are entitled to that benefit. Yeah. Right. Yeah. And there are all these comprehensive services therein, and so as a result of qualification and then starting the program, you get all of these services. Yeah. For free at no cost. You don't have to change your doctor. Okay. Okay. There's another question.
There's another question.
I jumped the mark.
No, it's good though. It's good. Perfect. It's good.
That's another thing about this program that you don't have to worry about. You don't have to change your doctor. Some folks, have relationships with their physicians 30 years strong, and they greet their doctor with a hug and kiss, asking about the kids and the family and how everything's going with their lives, and it is a more personal connection to them. Yes. There have been other programs that passively enrolled folks into the program if they qualify, just by virtue of seeing that they had these chronic conditions and that they were enrolled in Medi-Cal or whatever, and as a result they suddenly they have a different face talking to them as their primary care physician, and they don't trust this person, they don't know this person, especially if they had this 30-year-long relationship with a doctor. And so that really angered and upset people. This program made sure that did not happen. You can keep your doctor, and even if the doctor does not want to participate as what we call that CBCME, that community-based care management entity, if that doctor did not want to participate, I don't know why, but if they didn't, they could just be part of the care team. Okay. They could still act as the PCP, as the primary care provider, but they'll be part of the care team, communicating and inputting data to what we call the HAP, or Health Action Plan. This is a head-to-toe assessment, a head-to-toe assessment for all physical conditions, mental conditions, socioeconomic conditions, and that information is all placed in this document, and it's a dynamic document, meaning that when that patient goes off to see their specialist and there's another thing that happens, we're going to need to prescribe you this, that data is put on that document, to indicate to the rest of the care team,
Yes.
hey, we, okay, they prescribed Chris a medication for this. That means we shouldn't double prescribe or ask the patient to do double of a treatment. That would be dangerous.
Yeah.
And so there's that communication there. But yeah, the patient gets to keep their own doctors as a result.
Okay. Well, Chris, thank you so much. We have run out of time, and you have definitely expounded and did a lot of good explaining how this program work and what we can do as a community to push this program as a resource for me, because I'm definitely going to push it because it's a lot of great information.
Thank you.
It's a good program. And that's it for today's edition of Mental Health Matters. If you would like a DVD copy of this show, or if you would like to be a guest on the show, please dial 916-366-4600. Thank you.